Hello, everyone. Thank you for joining us today. We are excited to get started in this webinar. We're going to wait just another moment for additional attendees to join, and then we will begin. All right, I think we can go ahead and get started. Again, thank you for joining us. I'm going to turn it over to Lauren here in just a moment, but I would like to call out that the webinar slides for today's webinar are available within the materials link in GoToWebinar. We will send out the slides and a recording of the webinar as well after our webinar today. And we are excited to share the information regarding the proposed rule with you. Also, there is a questions panel within GoToWebinar. Feel free to shoot questions in there. We will go to the end. We'll probably take up most of our time, but we will spend as much time as possible answering questions at the end. And if you do not get your question answered, we will respond after the webinar and have opportunities after the webinar to engage with you as well. So with that, I'll go ahead and turn it over to Lauren.
Good afternoon, everybody. Today, it's another year, and it's another Medicare physician fee schedule proposed rule. So here we are. We've been through the proposed rule quite intently. It is 1,592 pages this year, not one of the longest ones, but still pretty hefty. And the good news is we've read it, and the good news is hopefully you don't have to. So what we're going to do is we're going to walk through the highlights as they pertain to quality reporting, to value-based care programs, and hopefully we can help you think about how you want to comment on the rule and what this means to you in terms of planning to go forward. And let's see if I can make the screen go forward. There we go. So here's what we're going to talk about today. We have 6 sections. First, we're going to start with MIPS, move to MVPs, advanced APMs, the ambulatory specialty model, and then we're going to talk about MSSP. But our MSSP overview, to be honest, is not going to be the full one. We'll do a second proposed rule to kind of like dig into all of the details and nuances on MSSP. And then how to comment should you feel that you really want to move that forward. So CMS tells you that there's 3 themes this year in the proposed rule, that they really want to focus on prevention and wellness. They want to reduce the burden for reporting. There have been a lot of comments to CMS about the burden in participating in these programs, and they want participation to be meaningful. They are trying. They keep putting forth new proposals, and as you well know, the last year has been filled with new proposals. They keep talking about how they're trying to reduce the burden. However, it feels like even though within perhaps the MIPS program, it is getting simpler, there's more programs that everybody needs to track. So for physicians and other healthcare providers, it's a really tough environment to navigate because there are lots of different rules. Like I said, we're going to cover 5 areas today. It used to be we covered 1 area. So even though the one area that we cover has gotten smaller, now we have additional areas we have to cover. So diving into MIPS itself, there are some key program changes. Like I said, they really are trying to simplify it. As you can see here, The proposal is to sunset traditional MIPS. So they're looking at advancing MVP as the alternative while folks move into other value-based care programs. But in the meantime, they are saying that anybody that is still in MIPS will need to move to the MVP program by 2029. So that is a date that they've put out there. We'll see if it sticks or we'll see if it changes. In terms of quality measures, again, simplification is the word that they use. Our quality measure inventory is moving from 190 measures to 180. However, they are making some additional changes which do sort of make everybody need to stand up and take notice. So where we used to talk about high priority measures, we're now moving into a concept called core measures. So the core measures replace the current outcome high priority measures that we've been required to report in years past, and they've designated 73 of the 180 as core measures. That seems a little bit odd in that, so many, what's that, like 40 some percent are core measures, but really the focus is coming up with 2 to 3 core measures for each specialty that are meaningful, that they can move into the MVPs, probably move into the ASM programs as they advance that, and really focus on those. The rationale is they want to be comparing apples to apples when they look at quality performance. And so they really want to target everybody working on the same quality measures. You have to report at least one core measure. If you don't, you'll get a 0 for your 6th measure. So it's really important to do that. 6th measure for MIPS, and we'll talk about the MVPs in a moment. So what is a core measure? CMS says for a specialty or condition, these are the measures that they feel matter. And we want everybody working on them so that we can compare meaningfully. They really are trying to consolidate, focus. We have seen this a little bit in the MVPs. They're narrowing them even more. And we see these when we talk about the ASM program as well. So the core measures, each measure counts as one measure. If you say you have no core measures that apply, you can attest to that, and you can have that not count. And this does not impact small practices. So again, they sort of call out small practices as trying to reduce the burden on them as much as they can. They use the defined benchmarks. They're not subject to 7-point top-down measurement anymore, so you will be able to get a full 10 points on all of the measures. And again, replace the outcome and high priority measures that we had in the past. So here's a list of all the proposed core measures. There's quite a list here. You're probably not going to be able to peruse these in the 60 seconds that we're giving you here to look at, but you can download this and take a look. Again, as we move into MVPs, probably want to look at them from that perspective as well. Again, you need to pick one of these at least to report. And then what we've done is we've taken the list and we've qualified it by each MVP. There are now 30 MVPs, so each MVP has at least 2. They've tried for 3 so that you have something to choose from. And this is, again, core measures by MVP. Pretty straightforward. I think I'm going to pass it off to Phil here.
All right. Thanks, Lauren. So before we start talking about benchmarks, I actually want to introduce 2 brief polls to just get some feedback from our audience. So if you wouldn't mind participating with us, we'll be able to share the results and then continue on with benchmarking. So I'm just going to start by launching our first poll. How closely have you followed the proposed rule so far? We know this came out very recently, but just trying to gauge how much our audience here has viewed what's been available in those days. I'll just wait another moment here as we've got some great participation. So any last responses? And I'll go ahead and close the poll and share the results. Okay, so it looks like for most, you've been able to see the, oh, I don't know if we lost our poll there, but you've been able to skim the proposed rule, but not take too close of a look. So this is hopefully helpful to reinforce some of the things that you've received from the polling, from the reading and skimming, and then give you a little additional depth. So we're going to go through with one additional poll here. And the question here is, which part of the proposed rule are you most concerned about? We covered the sections of our, or structured the sections of our webinar to cover those different sections from the proposed rule. So just kind of as you start and attend this webinar, what sections concern you the most? All right, and just another moment here. Okay, and I will end and share the results. And for the majority of you, it is the MVP and quality changes that are most concerning. So we are covering that, and we'll certainly continue to provide additional detail. As Lauren mentioned, we are going to share these slides that have those measures listed out for MVP core measures and quality measure changes. So you'll have those easily available at your fingertips. All right, I'm going to go ahead and close the poll. And now we're back to benchmarking. So for the proposed ruling in 2027, there are a few changes as they relate to benchmarks. The first being related to defined topped-out benchmarks. So if you recall, starting in 2025, this was a change to allow topped-out measures within specialty measure sets or MVPs to have different benchmarking to allow for more clinical relevance and participation. So CMS basically said you can still earn up to 10 points in those measures to encourage participation. Well, now what's being proposed is that should one of the measures with the defined topped out benchmark no longer become topped out, that it would revert back to historical benchmarks. So recognizing that there may be changes within the overall benchmarking and historical scoring that could change those benchmarks. And I think it's just more reason to pay attention to annual changes within the measures and their scoring related to those benchmarks. Also, CMS is proposing to move the list of those benchmarks to the QPP site instead of the federal registrar, making it easier for participants to view those measures. And then the benchmarking will also become flat for some of the MSSP related reporting. So the Medicare CQMs, which as Lauren mentioned, we're going to cover more in a separate webinar. We are going to touch on it a bit later on today as well. Will receive flat benchmarking, or that flat benchmarking will be extended. So that's going to impact a lot of the MSSP ACO reporters. And then also, as you've likely seen with anyone who's perused the proposed rule, a new collection type, Medicare ECQMs, is being introduced, and those would have flat benchmarking as well. And go to the next slide. All right, so a few changes for promoting interoperability as well, really aligning with the intended reduction of burden throughout the program. So we've seen CMS propose the removal of a few attestation-based measures, specifically the ONC Direct, ONC ACB surveillance attestations, and security risk analysis. You can see here when they are proposed to be removed from participation in the promoting interoperability category, and then also a change to electronic prior authorization. That would propose a optional participation in that measure for 2027 and then required in 2028. Additionally, they're proposing the inclusion of a new measure, electronic prior authorization for prescription drugs, which would include some additional criteria around how that measure is reported and scored, and that is proposed for 2028 inclusion. Some of the changes to CERT are also defined, which really align it with other programs and other proposed rulings. Some of it removes criteria for certification, again, just to make a more streamlined certification criteria across programs. Next slide. All right, so when we look at quality measure inventory, there's a number of new measures, there's measures removed, and as always, measures that are going through some level of substantive changes. Here we're just highlighting some of the measure proposals, including the new measures. You can see them listed out, LDL-C monitoring and management. The next one will go into a little more depth, some changes related to functional improvement measures, the addition of an age-related hearing loss evaluation measure, and then the remaining additional measures, patient experience with anesthesia, intraoperative hypertension, and SGLT2 inhibitors for CKD. If we go on to the next slide, we'll see those spelled out a little further. So you can see the list here of new proposed measures. And one of the biggest changes is the removal of some of the functional status measures or photo measures and replacement with measures that are a little broader in perspective. So we'll touch on those in a minute here, but we also want to have this available for you to review when you download the slides and can reference those measure changes. We also list here which of these measures are considered core measures. Again, you're going to see that core measure distinction pop up more throughout the ruling and when you're looking at the changes in regards to traditional MIPS measures and MVP quality measures for 2027 as well. All right, so 20 quality measures have also been proposed for removal. And again, all in alignment with reducing burden and streamlining reporting requirements. CMS has said that removal of quality measures falls into really three categories. If those measures are no longer maintained by their measure steward, you can see the list of measures here, really meaning that the measure steward, for whatever reason, is no longer supporting that measure. It's no longer in the CMS measure inventory. There's a series of measures that have ended their topped-out life cycle, really indicating that overall performance in those measures was maintained at a high level. Everyone was scoring well. They became harder to achieve a complete score on, so they are now being removed from the inventory as well. And then as we touched on briefly, a change in measures related to functional status change, removing some measures and then implementing new measures to replace those that allow for a little broader participation.
Some of us are super excited about that.
Yeah, it's going to be a challenge overcome for many of our providers as we've spoken to them about what this represents. So we're excited. And then you can see there a note as well. The Pro-PM measure really had limited adoption and is being removed too. Next slide. All right, and here again, just a list of the proposed measures for removal. You can see what those are and reference that. I'll list it out as well as the rationale. We want to make it easy for you to understand why measures are removed just as CMS has provided that information to us. So we'll go on to the next slide. And now we can talk a little more about what that measure, functional status change, change in measures represents. So as Lauren mentioned, we're excited about this because the photo measures were focused in therapy and targeted the use of a specific tool in order to report the measures. So great if you're using that tool, a little more challenging if you're not using that tool. So certain therapy providers found it difficult to report those measures. So what CMS did in working with a number of different entities related to musculoskeletal care said that those measures would be removed and then replaced with measures that use a broader set of assessment tools. So covering similar body parts or body regions, the list of measures is moving from 7 functional status measures to 5, and going from the use of the photo tool to the optional use of promise assessment tools or legacy assessment tools for the relevant body parts those assessments focus on. So again, this is something we highlight here because for our therapy providers, it's been a challenge if they're not using photo. This allows for broader participation within these measures and a on-ramp from the legacy assessment tools as are listed here towards promise assessment tools. What's interesting too is you can see called out the body region for back, replacing the quality measure 220 low back is a core measure. So that aligns really with the ASM low back pain cohort, and you'll see a change in that measure set as well. But just again, reiterating and emphasizing the streamlining of reporting and reduction of burden throughout the ruling. Lauren, any other comments you'd like to make here?
I just think that this vastly simplifies everybody's ability to report. So these are the functional outcome measures, and big shout out to Limber and Julia Becker and her team for working through this, and CMS for listening. And this is just, however, the functional assessment. The pain assessments will still be QCDR measures at least next year, and we'll see what happens with those going forward.
Awesome, thank you. And yeah, I don't think I recognized that the measures that are being added are really being moved from QCDR measures into the CQM measure sets. So those are available for all, and some may already have experience with those measures.
They are, my understanding, we don't have the full specs yet, but they will change a little bit from when they were the QCDR measures. CMS has a lot of rigor they wrap around actually creating a CQM. So you will have to take a look at those specs as they come out and get them implemented appropriately.
Awesome. All right, I think we're ready to move on. So improvement activities, as we experience each year, the inventory gets adjusted. We've got 6 additional measures, 11 measures removed. You can see this list here. Don't need to go through all of them in detail, but they're really trying to continue to hit on the wellness area as one of the focuses of the proposed ruling, and measures have been removed from a range of different categories of improvement activities. So like you do each year, you should take a moment to review the added and removed improvement activities, see if they are activities that you have been using and need to update your approach or plan to implement a new improvement activity prior to the new year. And as we'll talk about later on in the year, of course, you can always comment about any removals or additions through the comment period of the proposal. All right, and then reweighting deadlines and registry oversight, some additional kind of quick hits from the proposed ruling that CMS has looked at the EUC reweighting and determined that there is a narrow scope for that reweighting due to CMS looking only at PICO data sources for determining who receives an extreme and uncontrollable circumstance reweight. So basically, they're opening up that definition so they can use other sources to determine who receives the reweighting and then reweight appropriately. Regarding third-party submissions, CMS has extended the deadline for participants who notify CMS of a failed submission. So post-submission, a participant can communicate to CMS of whatever issues may have occurred with their submission, and that now has an extended deadline from November 1st to December 31st. And then really hitting QCDRs and qualified registries. There's a number of additional regulations being proposed that are really emphasizing additional oversight and making sure that qualified registries and QCDRs are participating appropriately. So you can read through these, really related to any lapses in participation, making sure that there's appropriate auditing, appropriate levels of performance feedback, and submission as QRs and QCDRs are assessed by CMS from 1 year to the next. So we are certainly on the HealthMonix side here, attentive to these changes and making sure that we're always meeting requirements as defined for our status as a QCDR and QR.
Yeah, we've noticed quite a bit of additional oversight from CMS for registries, for what it's worth. I think we just saw yesterday that there was some additional remediation and actual terminations that are occurring for registries. So not to self-promote, but if you're looking for a registry, just make sure that they're up to speed on all of the regulations and doing everything as they ought to.
Great, thanks, Lauren. And as we go to the next slide, I'm about to turn it over to Lauren, but I want to introduce just one additional poll here. So I'm going to pull that up and ask once again for participation. How ready is your organization for the shift toward MVPs and away from traditional MIPS? We just introduced the proposed timeline for the sunsetting of traditional MIPS towards MVPs. So how ready are you for it? And I'll give just another moment for responses. And close out the poll and share the results. So it looks like our majority are still evaluating MVPs, certainly understandable, with the next highest grouping are those already reporting an MVP. Great. We'll go through some additional changes to MVPs and encourage everyone as we go through those. This is the time to pay attention and understand how you can participate in an MVP, what MVPs are available to you, and what changes you need to make to prepare for the eventual sunsetting of traditional MIPS.
So thanks, Phil. This is where we really cross from, okay, so we were all about MIPS for several years, and then MVPs have sort of come on to our landscape, and for the last few years, they've really been optional, and they're still optional, but we're really seeing a push towards they're going to land, and we need to get ready. And they do add, while each MVP in and of itself is simplified, they do add a level of complexity as we go forward, because it's more options that you can track. And when we start talking about groups and subgroups and individuals, it can get complicated. So the first thing to discuss is CMS has proposed 3 new MVPs for 2027. 2 of them, I believe, are chronic conditions, diabetes and hypertension. And then the third is a hospitalist MVP, which really sort of has been lacking, and they've put forth that third one. So no MVPs are going away. There are 3 new MVPs proposed for next year. So 2 areas here. Number 1 is all of the MVPs. I think the theme here is core measures. They will all get core measures, next year, and some of them will have expanded measures. We didn't put them all in the charts here because with 30 MVPs, and some of them have as many as 15 various quality measures, let alone all of the other options with cost measures and so forth. So virtual groups can finally report MVPs starting in 2029. So 4 changes to MVPs. One is they're adding the core measures. They're adding measures for more clinical concepts and specialties. They're addressing some public maintenance requests, and just making sure they clean up anything that's been dropped, like the photo measures that Phil mentioned earlier. So the other thing that they're doing is they're going to start including that in physician compare, care compare. Those are going to get put forth as potential reporting on the public sites. So you'll want to watch for that. I'm not sure how many actual beneficiaries use those tools, but someday they may come to note for beneficiaries that are looking at service comparisons. Advanced APMs, just a couple of changes here. Today, QP status is at the NPI level. So if a provider receives QP status, they have QP status across all of their TINs. And the proposal is that it will be at the TIN NPI level. So it will only apply to those TINs for the NPI where they hit the threshold. So it's not a total QP status. So that you'll have to pay attention more to, are you hitting it on every TIN for which you are being held accountable. And here's just a subtlety. CMS had planned to continue to up the thresholds, both for partial QP and QP status. However, and you can qualify at the payment amount and at the patient count. So those were going up. And then what happened was in 2026, due to some congressional action, the thresholds we're not sure if they're going to cycle or if they came down and they're going to go back up again, but just something to really watch for is where do those thresholds hit every year, because that's a big determination in terms of who needs to report their quality metrics, IA and PI for the MIPS program.
Awesome. All right, I'm going to jump back in here, and before we dive into ASM, we're going to introduce our last poll. And as you could probably guess, it's related to your preparation for ASM. So the question is, on ASM, where does your organization stand? And given just a few moments for responses for that poll question. And we appreciate the engagement here. Always good to see where the audience is in relation to the material we're covering. All right, so we'll go ahead and share the results. So interesting, the majority here are unsure whether it applies to us, and then the next largest group knows it's not applicable to them. So I just encourage, as we go through this next section, there's a list of providers, individual clinicians who are required to participate in ASM. So if you're not sure, you can give us a call. We're happy to talk through how to find that out, but you'll want to make sure you know, as it's becoming a reality here soon. So I'm going to close the poll. And let's talk about the ambulatory specialty model. So as Lauren mentioned, there's a lot of new models that have been implemented or proposed within the last year, this being one of them, that really focuses on aligning specialty participation and apples-to-apples comparison across measurements. So if Lauren, you could hit the next slide for me.
Sorry.
All right. So as Medicare's first mandatory specialty model, what CMS is doing is saying, we're going to take two cohorts of clinicians and allow them to participate in a more focused approach with specialty measures, with aligned cost measures, and again, make a more apples to apples comparison of those participants. So they've said the two cohorts for the initial ASM model would be the heart failure, which really applies to cardiologists, and low back pain, which spans a couple different specialties, but orthopedics, pain management, and physical medicine. That list of required participants has been determined based on a set of geographical areas, and then providers have been more or less sampled or picked from that geographical area to create an initial list that will then be updated to or finalized for a list for 2027. So you do see some questions coming through. The list for ASM is not finalized, but really, if you're on that list, it's likely that you will participate. So it is possible you haven't been added, and there could be some adjustments, but there is the initial list for ASM participation available at this time. The way that the actual program would be assessed is similar to MIPS or traditional MIPS in the sense that there's a positive and negative swing available based on performance in a set of measures across the same performance categories that exist for traditional MIPS. But as I mentioned, the intent is that a cardiologist doing heart failure is only getting measured against other cardiologists doing heart failure so that the measure performance is a better comparison for those participants. Again, you can receive a positive, neutral, or negative adjustment, and that adjustment occurs 2 years after your initial participation. And from a timing perspective, this is proposed, but really we're seeing it be solidified for an initial performance year of 2027, and then having 5 years of the program ending in 2031. The participation is at the individual provider level. It's identified at the TIN NPI level. So it is a clinician by clinician based on the TIN the clinician is participating in. And important to highlight here, where we have seen MIPS really communicate a positive to negative 9% swing, the ASM is really focusing on a true positive to negative 9% based on the scoring and penalties. And CMS has communicated that that range of adjustments will increase to a positive or negative 12% by 2031. So this really has some teeth to it, which is why we truly encourage participants who may be eligible to confirm their eligibility and confirm after the finalized list is available as well. And CMS does intend to expand this model to additional specialties. As you can see a note on the bottom related to heart failure and low back pain, it targeted these two conditions to really begin the program and then include additional conditions and specialty providers moving forward. All right, go to the next slide.
Sure.
From a scoring perspective, as mentioned, the structure of ASM will continue to include quality, cost, improvement activities, and promoting interoperability. But instead of an even breakdown, or as we experience a 30, 25, 15 split on performance category weights, we get an even split between quality and cost at 50% each. So there's a concept of a base score based just on those two performance categories. So you need to participate in the defined quality measure set and cost measures for each ASM cohort. And then the improvement activities and promoting interoperability would be required, but implement a negative adjustment if those performance categories are not met fully. We're not going to go in too deep into that. We've got previously done webinars on ASM specifically, but just want to set the table with the scoring structure. On the positive adjustment side, there's positive adjustments for complex patients and small practice participation. You can see what those are. And then from the base score and any negative or positive adjustments, you'd receive a final score. And then that final score impacts the incentives or penalties that you would receive. So what does ASM look like in the lens of our proposed rule that we're talking about here today? If we go to the next slide, we can see really CMS is just emphasizing the structure that was laid out and providing a few operational refinements. So no major changes here, but they are indicating new participant expectations, including exceptions for providers changing TINs or redesignating their specialty. So allowing for a little more change to occur based on how a provider is recognized within their TIN or specialty with CMS. There's also some added reporting flexibility related to small practices and the data that those small practices are reporting, and allowing for more favorable scoring based on those submissions. You can see a new measure also included for administrative claims, so that measure set will be adjusted slightly. And then the change in measure, as mentioned, related to the removal of one of the photo measures, quality measure 220, and then the additional of measure 182 within the low back pain measure set. You'll also see some changes to patient-reported outcomes for those voluntarily participating, and then data completeness requirements were defined for the quality measures to align with what exists today in traditional MIPS. So, it's been interesting as we've talked to potentially included clinicians or those already on the inclusion list for ASM. We've heard some feedback around those who are not ready or those who don't believe it's true or going to come. We're seeing CMS saying this is real, so be ready for it and prepare. And I think the proposed ruling is just reemphasizing that this is something to be aware of and be ready for when it comes in 2027. All right, we can move to the next slide. So what does this mean for specialists? There's no opting out. CMS has not provided additional off-ramp for ASM participation outside of what we just discussed. So really, you should treat it as a certainty and begin planning. The performance thresholds are really going to be set and allow for a positive and negative adjustment. We'll continue to learn more exactly, what that looks like, but I think again, it's just doubling down on what we know about ASM and preparing as a group for any potential or named clinicians within your group who are going to be included within the program. And as we talked about already, there is overlap with the traditional MIPS reporting requirements, certainly by the performance categories that are defined within each program. But there's this reality that as a group, you may have participants in multiple reporting mechanisms. You may have providers participating in an ACO, in traditional MIPS, in ASM. So you got to prepare for all of those. But CMS is doing its best to align reporting requirements to ease participation in each.
Yeah, so I think the gotcha with ASM is there are 4 quality measures that you must report. and it gives you no flexibility in terms of what you're reporting. So if you're if you're a provider that's already participating in MIPS, you've really got to take a look at those 4 measures and get ready to do well on them for 2027. And it really is a case where they're taking, I think each model probably has, each of the cohorts, I would guess 6,000 to 8,000 physicians that are designated, and they're just going to be ranked. And if you're at the bottom of that list, then you are going to see a penalty, and it's different from what they've done in the past, in that it is, it is plus or minus, not minus 9%, and it is 4 specified quality measures that they will be ranked on.
All right, and with that, I think we're sticking with you, Lauren, for MSSP quality reporting.
Section 5. Remember the days when it was PQRS and there were 20 eligible instances? Life was so much easier then. Okay, when we look at MSSP, we're not going to cover everything in detail. We will do an additional webinar, but this sort of gives us the highlights. There are 6 moving pieces this year. The highlight is there's a new Medicare ECQM collection type. So what this is for those of you that are already participating, if you are participating, you may be reporting the Medicare CQMs. They are now going to have, they're now proposing to have Medicare ECQMs in 2027. So it would follow the ECQM specs, but it would be based on the ACO's beneficiary population. So along with that, note that they're proposing to change the way the beneficiary list is generated to make it more aligned with the beneficiaries that are actually assigned to the ACO versus the way they do it now. It's a little bit different. It's like a combination of how many times a beneficiary saw a provider in the ACO and a couple of other rules. They're just saying, let's go back and let's align it with which beneficiaries are attributed to that ACO, which in my mind makes a whole lot of sense. So that's change 1. Change 2 is that they will have flat benchmarks for all of the Medicare CQMs, and this is going to be applied retroactively to this year. So all of the measures for Medicare CQMs for 2026 are proposed to be flat benchmarks. They will not be deciles. Change number 3 is that they are going to continue to allow submission of MIPS CQMs. They had talked about sunsetting that in coming years pretty swiftly. They wanted people to move to ECQMs. They still do. Their goal is to get everybody using FHIR DQMs at some point. But I think that it's challenging. ACOs, MSSP ACOs in particular, have a lot of different data that they're combining, and it's just been a real challenge for everybody to make this transition. They've changed a little bit about CERT in terms of what the use requirements are. Actually, this is kind of nice. They've said that in the past, it used to be you had to report 100% of your beneficiaries across all of your EHRs. They're making a special case that if you have an EHR that is not meeting the requirements, that you can exclude those patients and providers from your reporting as long as it's not more than 5% of your eligible population. The APP Plus measure set, they had proposed adding 305, which is substance use disorder and adult immunization status next year, and they're talking about not making that a requirement for 2027. And then the last piece of what they've put together is they're seeking comment on applying the electronic prior auth measure to the MSSP participants. That's a mouthful. So here's the proposed quality measure set for 2027. you will see it looks pretty, at least the reporting measures are the same measures as we are doing currently in 2026. So that's a little bit of a relief. And the 8 measures are listed here. I think this is a win.
All right, so I'm going to jump back in, and I'll say as we're getting to our last section here, we appreciate the questions that folks have been asking so far. I'm going to go through this last section, and we'll see if we have some time to answer those questions. Again, we'll get back to you if not during our live webinar. And just to answer one consistent question, we will send out the webinar slides and a recording of the webinar after our webinar as well. All right, so CMS has got a lot going on here, and they even included sections where they're requesting feedback in terms of RFIs. So there's a lot that you can comment on and help shape what these programs look like moving forward. But just to kind of reiterate some of what we've covered here, there are some things that are not changing. So traditional MIPS is really holding true for 2027 and 2028. The reporting requirements, including the thresholds, performance category weights, and data completeness, are staying the same. So CMS is saying we want to make it easier for you to participate in MIPS now and get ready for MVPs as that becomes required. So MVPs are still optional, but it's proposed that those become mandatory by 2029 and follow some of the same criteria in terms of performance categories, but would really require closer attention to the measures being selected, understanding that you're reporting on less measures, so that might benefit you or hurt you depending on the measure performance, and you're doing 4 measures instead of 6. And then as we look at ASM, really again a kind of more refined or more specific to specialty providers version of participation that is starting with 2 cohorts and has real teeth to it in terms of penalties and incentives. So all of these together are things that are staying the same largely, but as we move into some of the changes, there's opportunities to comment. We go to the next slide. So we're seeing this shift in accountability toward an entity level with changes to some of the exemptions and incentives, tracking the billing, not just the individual. I think you've seen that a couple different places, including not just following the PCOS definitions, but a broader set of definitions. And then also the QP and partial QP determinations. We see the really focus on specialists. It's been interesting as we work with a number of ACOs. For many of those, their specialists may have been removed from the ACO and have moved from ACO participation in the past to reporting MIPS. And now you've got MVPs coming on. So a potential complexity of just managing multiple programs for different provider types, whether you're an individual provider, or a larger organization or even ACO. But being able to track and understand performance in each of those programs is going to be critical for appropriate participation. And then we're seeing this consolidation of measures, refining of measure sets, removal of measures, and standardization. We haven't even talked about DQMs, but that's a different topic for today. But CMS is continuing to push for aligned measures across the board and making sure that the measures that are available are relevant to providers participating. And we go to the next slide. So there's a number of ways to comment. Comments are due within a 60-day comment period. We're including here the ways you can comment on the proposed rule. And if you've been attentive to each ruling, you know that in the final rule, there's a number of comments that are addressed. So CMS does listen to comments and can make changes on ruling based on the feedback. So we encourage you, as we will, to take a look and comment on the sections that are most important to you. And then we can kind of go through some quick hits here as we close out. I know we're already getting to time, but there are 3 requests for information where CMS is looking for comment. This isn't just comment on existing rulings, but comments to help shape what requirements look like in the future. So those are broken down into FHIR-based digital quality reporting, MVP scoring methodology, and then star rating assignment methodology. So we encourage you to take a look at those and make comments where appropriate. So as we've talked about, there's this potential for added complexity due to these different programs. And we really only touched on traditional MIPS, MVP, and ASM. There's other programs out there that your providers may be included in and required to report for. We at HealthMonix are here to help. We've continued to evolve to meet requirements for these programs and support our clients in meeting what's required of them today and prepare for what's coming next and in the future. So whether you've been on our webinars in the past or are new to us, our PRISM platform does just that. It takes in data from a number of different sources and allows you to see performance in different groupings of providers, in different programs, and allows for drill downs into different things to understand how to best address performance opportunities and close gaps in care. So we keep going here. Just a few kind of dashboards, whether again you've worked with us in the past or not. We really pride ourselves on bringing tools that allow you to view how you're performing within the measures that you are responsible for or selected, and then also allow you drill down capabilities to better understand how your performance is impacted. So we go to the next slide. In addition to top level performance assessments, we also provide actionable insights in dashboards that drill deeper into measure requirements and showing you not only what your performance is, but who's making up that performance and why you may not be hitting performance on specific measures. Next slide. And then just to highlight as well, as we look at these different programs, it's not just quality. Certainly everyone's participated, or many of you have participated in promoting interoperability and improvement activities, but we also have tools to address the cost category, really opening up what many clinicians think is a category that you cannot impact. We can provide tools to allow you to gain insight into where you stand in your cost measures today, and make changes to help you moving forward. And as we close out here, again, we want to welcome engagement from you. If you didn't have the chance to get your question answered, and we're already running out of time here, so we will take time after the webinar to address questions. Please reach out to us. We'd love to talk through how the proposed rule may affect you, help you plan and create strategy around participation in traditional MIPS, MVPs, ASM, or other programs. And as we mentioned as well, we'll be doing another webinar to dive deeper on the proposed changes that impact MSSP ACO reporting in another time. So again, thank you. It's been really great to be able to share this information with you. I know our team dives into this regularly, and hopefully, as Lauren said, it can save you time from needing to go as deep on this material. So as we wrap up, I'll turn it over to Lauren for closing comments. But again, you'll get the slides, you'll get the webinar recording, and we appreciate your time spent with us today.
Yes, thank you, everybody. And we will definitely reach back out with answers to your questions and look forward to diving further into many of these topics as we go forward.
All right, and that we're coming to an end. So once again, we appreciate your time and hope you enjoy the rest of your day.
Thanks, everybody.